Hello again. Good afternoon, ladies and gentlemen. I would like first, Professor Tinica, for your kind invitation to participate to your Congress, 10th Congress of Romanian Society of Cardiac Surgery. So I'm an anesthesiologist and intensive care specialist, and it's praised the ambition of the surgical community to be more close to the problems of anesthesia intensive care. But honestly, there's one personal reason for me to be in Romania. My roots are from your country. They come from mid-19th century, and but now are scattered without trace. Part of me is a Romanian, but I'm trying to find out how big is this part. Okay. Yes, I'm working in intensive care of University Hospital St. Ekaterina. This is the leading hospital in the field of cardiology, cardiac and vascular surgery in Bulgaria. We perform close 1,500 cardiac surgery procedures, about 1,000 vascular main arterial reconstructions, 4,000 interventional cardiac procedures. More than half of them are accomplished with stent implantation. To be anesthesiologist and intensive care specialist in cardiac surgery is a real challenge. This is perhaps the most technical field in medicine. In many cases, the man on the bed is lost among technology. First, the anesthesiologist has to survive itself and simultaneously to save the life of his patient. The patients in cardiac surgery programs became older and more sick. Can we predict the process of recovery or deterioration? In cardiac surgery, there are several scoring systems intended for evaluation of the probability of death in perioperative period on the basis of preoperative data. These systems you can see are Parson, QMMI, Cleveland Clinic scoring system, French scoring system, Ontario, Euroscore, and others. The Euroscore system was created in the 90s of the last century and has become widespread in many European countries as well as outside. Almost 20,000 consecutive patients from 128 hospitals in 8 European countries were studied. Information of many risk factors was evaluated. The outcome, survival or death, was related to the preoperative factors. The scoring system was prepared for a part of the database and tested and validated on another part. The most important, reliable, and objective risk factors were then used to prepare a scoring system. They are patient data, as you can see, heart function, and surgical procedure-related factors. But I'm not so here to talk about Euroscore in depth. In this room, I hope there are enough surgeons familiar with this matter. It is accepted that patients with high Euroscore to have high mortality. What happens to the high-risk patients in the postoperative period? It is impossible on the basis of preoperative data to predict the consecutive events. Several systems are created to evaluate the changes in body functions and organ functions in the ICUs from the day of admission and day by day. They are formulated on different countries, institutions, on the basis of different patient populations. The most frequently used systems are Apache, Simplified Acute Physiology Score, Multiple Organ Dysfunction Score, Mortality Prediction Model. In, as I mentioned earlier, common intensive care scoring systems have excluded cardiac surgical patients in their construction. The acute pathophysiological sequelae of cardiopulmonary bypass are transient, and many physiologic changes may be masked by multiple system support devices, such as aortic balloon pump, ventricular assist device, hemofiltration, or mechanical ventilation. A scoring system for cardiac surgery patient was developed by cardiac surgeon Korso Heckmat in Cologne, Germany. They call CASUS. CASUS scoring system is superior a patient MSOD for the first and the second day. But after the third, prognostic value of three systems are aligned. In the 90s, leading intensivists in Europe, separately and jointly, introduced into clinical practice new scoring system. They call it sequential orthofailure assessment. This system, as Alda stated above, is created for patients in several general intensive care units. The degree of 6 vital organs is gradually evaluated from 0, no abnormal function, to 4, severe dysfunction. Lung function is evaluated by oxygenation index, kidney by level of creatinine, liver by the level of bilirubin, cardiovascular system by mean arterial pressure and need of inodrops and pressors, coagulation by the level of thrombocytes, and neurosystem through Glasgow's Coma Scale. Using Sofia, we can measure postoperative morbidity day by day, can predict mortality, or evaluate the effectiveness of treatment. May be a basis for comparison between institutions with similar patients, or comparison between the teams in a particular institution dealing with patients with the same characteristics. The general scoring systems are for evaluation of patients in general intensive care units. CASUS systems works well till third day, but we are interested in patients' condition for the next day. So we organized a study to evaluate the feasibility of SOFA system for evaluation of postoperative morbidity and mortality in a limited group of patients after cardiac surgery after the third postoperative day. This is a prospective observational study performed in the setting of intensive care unit of University Hospital St. Ekaterina, Sofia, Bulgaria. All consecutive patients with pump cardiac surgery operations were included in the study. Because this is an observational study, no change in routine practice was done, and informed consent was not applied. Design of the study: 612 patients operated on entered in the study. In the preoperative period, the Euroscore was calculated based on the model proposed in European Association of Cardiothoracic Surgery meeting in Lisbon 2011. 451 patients were discharged from ICU till 72nd postoperative hour and were not evaluated thereafter. 161 patients treated more than 3 days were studied. In this population, SOFA score was calculated every day till discharge or death. For each organ function, we take the lowest value for the day. In these patients, we studied mortality in ICU, length of stay, length of mechanical ventilation, occurrence and duration of renal replacement therapy, and therapy with an intra-aortic balloon pump. In the studied patients, preoperative Euroscore is 7.4 and average SOFA score was 9.5. In patients studied, there is augmentation of cumulative morbidity. Cumulative SOFA score on third day is 8.8, but on 9th day, it's 10.2. There are only 38 patients evaluated in 9th day. Euroscore patients discharged from ICU till third day is 5.4, and mortality is 1.8. In the remaining patients treated in ICU more than 3 days, Euroscore is 7.4, SOFA score is 9.5, and mortality is 16%. There are 135 survivors and 26 non-survivors in studied group. In survivors, SOFA score on third day is 8.1 and preoperative Euroscore is 7.5. In non-survivors, SOFA is 13.3 and Euroscore is also 13. Survivors have length of stay in the ICU 6.5 days. Mechanical ventilation is below 2 days. Close to 8% of them are on continuous cylinder replacement therapy in balloon pump on third day. In contrast, non-survivors have prolonged period of treatment in ICU close to 3 weeks. Mechanical ventilation is above 2 weeks, and almost 40% of them are on continuous cylinder replacement therapy and balloon pump compensation in the entrance of the study. You can see average values of SOFA score and direction of change in cumulative morbidity in survivors and non-survivors. Although SOFA score in non-survivors is with decreasing level, it never reached even the high values in survivors. So, survivors are with a tendency to improve oxygenation in the end of the first post-operative week, while in non-survivors we can see further deterioration of oxygenation. It is not unusual to see in non-survivors PO2 around 60 or 70 in spite of fraction of oxygen above 80%, and continue ventilation in prone position, keeping in mind lung protective ventilation policy. In non-survivors, coagulation seems to be improved, but is worse than in survivors. Non-survivors are with a major depression in systemic hemodynamics compared to survivors. Actually, the generator of multiple system organ failure assessed by SOFA is a low cardiac output syndrome. The more suppressed is hemodynamics, and in particular the heart contractility, the more pronounced is dysfunction is in other vital organs. Concerning the function of liver, it is the same upward direction, the bilirubin in both groups, although the levels are different. So as with oxygenation, the difference between survivors and non-survivors is in the same way. Concerning the degree of brain dysfunction was the same. Probability improving oxygenation and circulation determine faster neurological recovery and place the patients in the group of survivors in spite of the presence or absence of abnormal coagulation, liver, or kidney function. We have sought a common link between Euroscore and post-operative SOFA score, as we suppose we did not find a link between values on third post-operative day. Applying logistic regression model for survival, we found higher predictive value of SOFA on the third day against preoperative Euroscore. Area and receiver operating characteristics is different in SOFA and Euroscore, 0.77 against 0.63. On the basis of this data, we can carefully conclude carefully. In patients after cardiac surgery treated more than 3 days in ICU, Sofia score on day 3 allow prediction of postoperative mortality perhaps better than Euroscore. It may sound hard to surgical audience, but in other words, it is more important the patient condition of the 3rd day than preoperative Euroscore. And after these words, I want to thank you for your attention.